Welcome back. In this next module, we can look at why we consider surgery for patients. There's not a one-size-fits-all approach to periodontal surgery. The correct treatment planning decision is based upon multiple factors. First, we must take into account the patient's medical history. In addition, we have to include the patient in the decision-making process, respecting their desires for treatment. After those considerations, we can focus on our actual periodontal findings. You must take into account the diagnosis, the severity of the disease, the location of the disease, whether it is generalized or localized, interproximal, or a furcation defect. You get the idea. And finally, we must consider the morphology of the defects, which will contribute to our decision-making process as to which therapy will lead to the best outcome. We have 5 objectives for surgical therapy. One is to provide better access than we could achieve non-surgically. Second, it gives us the opportunity to modify osseous architecture. Third, it enables us to either repair or regenerate the periodontium. Fourth, we should be able to establish some reduction in probing depth. And finally, we need to use our surgical techniques to establish acceptable gingival contours so that the patient may be able to maintain their dentition. The first objective is access. Just remember, you can't treat what you can't see. Being able to reflect a flap enables you to have increased visibility, increased efficiency, and cause less tissue trauma. This is an example of a patient with moderate to severe horizontal and vertical bone loss. Now, it is very unusual to have a mandibular premolar that has a bifurcated root such as you see here. However, I'm sure you can appreciate how hard it would be to thoroughly remove the calculus from this tooth using a closed approach. On the right, you can see once the defect has been debrided, we have some intrabony component, and we've got that nasty furcation to try to deal with. Our second objective is the ability to make changes in the bone contours, osseous modification. This is done to eliminate probing depths and to recreate a physiologic bone architecture. This can be an additive or subtractive process, which you will learn about in a future module. Our example here is a case of moderate periodontitis, where an osseous resective approach is used to produce a physiologic architecture. As you can see, upon flap reflection, we have very thick ledges of bone. We have a very flat architecture, and as we lead interproximally in these regions, we have some interproximal cratering. Following a combination of ostectomy and osteoplasty, 2 terms you'll learn about in a future module, you can see that we have established a much better scalloped architecture. We've initially thinned those bony ledges or exostoses, and also created a more favorable interdental gingival architecture. This is the same case after suturing on the left and reevaluation 6 weeks later. Note the establishment of the positive architecture, which the patient can now physiologically maintain and keep this dentition healthy. Our third objective is to promote wound healing. Wound healing can take on 4 different aspects. It could be either reattachment, repair, new attachment, or regeneration. The diagram that you see at the top shows the 4 different types of tissue compartments that can populate a wound. You can see we have epithelium, connective tissue, bone, and the periodontal ligament. Below this, you can see that the end result of the process is based upon the therapy you select. On the left, we have healing by the establishment of a long junctional epithelium. This is our most common type of healing which we will see after scaling and root planing and open flap debridement. You could potentially have connective tissue adhesion as demonstrated here, and root resorption as diagrammed in this spot. Also, there could be root resorption and ankylosis, where you can see the bone is directly fused to the underlying cementum of the tooth. These are all examples of a process known as repair. Our goal is regeneration, where we actually develop a new connective tissue attachment, and we'll be looking at these definitions a little bit more in detail. Repair is simply healing with a tissue that does not fully restore the architecture or function of the part. In this instance, think long junctional epithelium, which is the type of healing, as we said, occurs following scaling and root planing and open flap debridement. Reattachment means to attach again. There are a couple of key elements in the definition that you should be aware of. Reattachment means the reunion of epithelial and connective tissue with the root surface following separation by an incision or physical injury. It's important to recognize that both of these tissues are the tissues that actually attach back to the tooth, and it is not a disease-caused process. Here again, think about when surgery is performed and you've inserted a scalpel blade into a sulcus area so that you can gain access to a disease site. The healing would be by reattachment. Next, we have new attachment. New attachment is the union of connective tissue or epithelium with a root surface that has been deprived of its original attachment apparatus. You can really contrast the difference between this and reattachment. This type of healing can be either epithelial adhesion or a connective tissue adaptation or attachment. This type of healing does include new cementum. Finally is our gold standard in healing, and that's periodontal regeneration. Periodontal regeneration is defined histologically as the regeneration of three key tissues: bone, periodontal ligament, and new cementum. It is the reproduction or reconstitution of a lost or injured part. You may think here that what we're doing is recreating the area similar to its original form. Essentially, we want to restore that periodontium back and, if at all possible, regrow those lost structures. Our fourth goal of surgery is probing depth reduction. The goal is to improve access for everyone in order to maintain the dentition. This helps improve the long-term stability of the dentition. And finally, the last of our surgical objectives is to establish acceptable contours. Primary in this objective is to create contours to enable the patient to perform plaque control. In addition, the case you are seeing is one where we have gingival enlargement, most likely due to some drug-induced development. You can appreciate how difficult it would be to try to maintain hygiene with tissue contours of this magnitude. In this approach, the tissue contours will be reduced to establish a physiologic architecture and also improve aesthetics. This concludes this module on why we do surgery.